Yeah, thank you for joining us today. So I'll start by introducing myself. I'm Christine Marie George, and I'm a professor at Johns Hopkins. And Kelly.
Oh, hi everyone. My name is Kelly Andreas. I'm a faculty member with Johns Hopkins.
And it's our pleasure today to present on our randomized controlled trial, the Preventative Intervention for Cholera for 7 Days, or PICHA-7 WATCH program that was conducted in the Democratic Republic of the Congo. And for this intervention, we integrated in-person visits with mobile health messaging. And this work is a collaboration between our research group at Johns Hopkins, Catholic University Bukavu, and the DRC Ministry of Health. And our colleagues in DRC, unfortunately, were not able to get their visa in time for the conference, but they'll be presenting virtually. Seem to be having some clicking issues here. Here we go. And so the rationale behind the session today is that there's been large community-based WATCH programs that have really shown mixed results in terms of their health impacts, with some reducing diarrhea and others not, and only the CTLS study in Mali significantly reducing stunting in young children. And this has really indicated the importance of transformative approaches for WATCH, new technologies to deliver WATCH services, and different modalities to facilitate WATCH behavior change. And in this presentation, we're going to recommend the integration of in-person visits and mobile health messaging as a form of transformative WATCH. And we'll share evidence from our previous work in Bangladesh, as well as our current work in DRC, where we show this integrated approach significantly reduced diarrhea, as well as stunting in children under 5 years of age, in these two very distinct contexts. And so the overview for the presentation today is we'll start by going through our study rationale, we'll go into our project overview, and then we'll discuss the formative research that was conducted to adapt our WATCH intervention that we originally delivered in Bangladesh to our context that's very different in the Democratic Republic of the Congo. And then we'll go into our randomized pilot, where we developed the PICHA-7 program to promote hand washing with soap in a health facility setting among diarrhea patients and their attendants. And then from there, we'll go into the design of the randomized control trial, our health outcomes, WATCH behavioral outcomes, and then the process evaluation that was taken to develop the mobile health component of the program. And then we'll end with questions and a discussion around how transformative WATCH could be integrated into existing WATCH programs. And so, as I mentioned, I'm Christine Marie George, and I'll go through the project rationale. And so the rationale behind our study is that when a diarrhea patient is presenting at a health facility, their household members are at a much higher risk of developing diarrheal diseases than the general population during the 7-day period after the diarrhea patient is admitted to the health facility. And for cholera, for example, this risk is 100 times higher. And this is thought to be because they're sharing the same contaminated environmental source, such as drinking water, and also through person-to-person transmission through, for example, lack of hand washing with soap. However, despite this evidence from numerous studies, there's very limited interventions for this high-risk population, with the focus solely being on the treatment of the diarrhea patient, but not the promotion of WATCH among the household members at high risk. And so this led to our work on targeted intervention approaches for diarrhea patients and their household members. And so this work originally started in Bangladesh with the Cholera Hospital-Based Intervention for 7 Days, or CHOBI-7 program. And this was delivered in an urban context in Dhaka, which is the capital city of Bangladesh. And it's a health facility-initiated program. And so you have initial visit by a health promoter promoting hand washing with soap, water treatment, and safe water storage, bedside to the diarrhea patient and their accompanying household members. This is accompanied by a hygiene kit, which includes a water vessel with lid and tap, a hand washing station, and chlorine tablets. And then in our original form of our intervention, we included home visits to reinforce the behavioral recommendations from the health facility. And so in our original randomized control trial of the CHOBI-7 program among cholera patients and their household members, we showed that this intervention approach led to a significant reduction in cholera among the household members of cholera patients and led to sustained hand washing with soap and water treatment 12 months post-intervention. And so these promising findings were shared with the Bangladesh Ministry of Health and Family Welfare, And they said, we're interested in maybe scaling this, but they asked us to make some modifications to it. And so the first one was to broaden the scope of the intervention to include diarrhea patients of all etiologies. So the intervention could benefit millions more beneficiaries. And then also, they encouraged us to develop a scalable approach for program delivery that did not involve home visits, since home visits were something they couldn't take to scale. And so this led to our present day work on mobile health programs. So through formative research, we developed the Chobi 7 mobile health program, where a physician at a local diarrhea hospital sends out automated calls and text messages to diarrhea patients and their household members post-discharge, promoting hand washing with soap, water treatment, and safe water storage as a way to reinforce the behavioral recommendations given in the health facility. And these were sent out weekly for 12 months. And to emphasize the cost of this type of approach, it costs $2 to send out weekly voice and text messages for 12 months. And so it's a very low cost approach, and as we'll show, facilitated WASH behavior change. And so we conducted a randomized controlled trial of this Chobi 7 WASH program in Dhaka, Bangladesh among 2,600 participants, and showed that it not only significantly reduced diarrhea during the 7-day high-risk period, but led to sustained reductions in diarrhea out to 12 months, and significantly reduced stunting among children under 5 years of age. And this work was published previously in Clinical Infectious Diseases. And so building on that work, we were really interested to adapt this type of intervention for a sub-Saharan African context, and in particular for the Democratic Republic of the Congo. And this setting differs dramatically from Bangladesh in terms of much higher water scarcity, higher household size, and also much higher food insecurity. And so we were able to adapt through formative research, which my colleague, Dr. Basimwa, will talk about, and John Claude Basimwa, to adapt this intervention to this new context. And so our study site is located in Eastern DRC. We work in both North and South Kivu, and the activities today will focus on South Kivu, and this randomized controlled trial was funded by Wellcome. And so the intervention that we developed was the preventative intervention for cholera for 7 days. And the acronym is PICHA-7. PICHA means picture in Swahili for the pictorial WASH module delivered as part of the program. And then the 7 is for the 7-day high-risk period for subsequent diarrheal diseases. And so similar to the Chobi 7 program in Bangladesh, it's health facility initiated, same target WASH behaviors, hand washing with soap, water treatment, and safe water storage. We have quarterly home visits. And so in the Congo context, there's a community health worker infrastructure in the area that we're working in, which is also an urban setting. And so it's feasible to have quarterly home visits as a part of program implementation. And then this was accompanied by a mobile health program, and similar to Chobi 7, involved weekly voice and text messages from a physician at a local cholera treatment center. And so now my colleague, Dr. Lucien Basimwa, will be presenting on the formative research conducted to develop this intervention.
Hello, my name is Dr. Lucien Basimwa. I'm a doctor at Université Catholique de Bukavu in the Democratic Republic of the Congo. Today, I'm presenting with Jean-Claude Basimwa, my colleague. We will be discussing the formative research we conducted to develop the PICHA-7 program. We published this work in the International Journal of the Environmental Research and Public Health. Here are our pictures and contact information, as we could not attend in person. The 3 phases of formative research. First, we conducted exploratory interviews with diarrhea patients and their household members, and also with health workers recruited from health facilities treating patients with severe diarrhea in Bukavu. Semi-structured interviews guides were designed to assess hand washing with soap, water treatment, and safe water storage behaviors using the IBM WASH model of behavior change. Questions covered topics such as awareness of cholera and diarrheal disease, hand washing with soap, water treatment, and water storage behaviors in household and health facilities. Interviews enables us to design and refine a free book teaching module. Next, we conducted our first pilot phase, where we tested the Picture 7 program and followed up with households over a 1-month period. Households receive 1 visit in the health facility and 2 visits at home. All households received the Picture 7 intervention. We conducted additional semi-structure interviews after the 1-month period and refined the Picture 7 program. The first 2 pilots of the Picture 7 mobile health program was delivered weekly for 3 months. The larger program of the randomized controlled trial was delivered for 12 months. The key behaviors of the Picture 7 program follows those of the original intervention. Our first key behavior is hand washing with soap at food and stool-related events. We also recommend the use of soapy water or ash, which is a low-cost alternative of bar soap made with water and detergent. Our second key behavior is water treatment with chlorine tablets during the 7-day high-risk period and bullying if no tablets are available. The final behavior is the safe drinking water storage, in particular using a water vessel with a lid and a tap. Through our formative research, we were able to identify factors that influence these behaviors in the hospital and when patients return home and modify the intervention accordingly. The modified intervention included the addition of the mobile health program, increased household visit, locally sourced enabling technology to provide a jerry can for more water storage, and a tap with a slower flow was put on the hand washing stations to reduce water required for hand washing. The Picture 7 pilot included 3 components: a healthcare facility visit, home visit, and a mobile health program. During the health facility and household visit, flipbook pictorial modules were delivered by a health promoter. Each household received a cholera prevention package, including a hand washing station, soapy water, drinking water vessel with lid and tap, and a 1-month supply of chlorine tablets, and 4 Q2 action card for target behaviors. The mobile health program that included voice and text messages was delivered weekly for 3 months. The larger program was delivered for 12 months.
So here we have a video showing one of the quarterly home visits. So you can see here the hand washing that were delivered, just gives you a sense of the context of where we're
Na wenyewe
working.
mliona vile. Sasa kwa tu kitu mama kufasiria hapa banatuonesha kama unaweza tia mai
The video
kisha
can
kuyaza mai mule sabile tushatia mai yetu mule unatia kinini moya unachunga 30 minutes ndio tunaanza kunywa. Ndio maana kuko hizi masaa 30 minutes sawa. Mama tatutunzia mai. Tunikisha hii dawa unakamata hii moya unaitia mule mbegeti yetu kwa mai kisha tunachunga 30 minutes tunaanza kunywa.
And so he's explaining how to treat the water with chlorine tablets.
Okay.
So we have another video here.
Okay, tunatobola tunu ndio etape ya kwanza.
So again, this is
Unaona etape ya pili ni
we're using water and spoon leftover
tunasema mfuniko ngapi?
the 2 approaches that we have.
Merci beaucoup.
We'll just continue. You get a sense of activities there.
Okay.
This is an example interactive voice response, or IVR. Message sent during the mobile health program shortened to fit on the slides. IVR messages send a short quiz to participants. Correct and an incorrect explanation are provided based on the reply. We will discuss the mobile health program later in the presentation.
Yeah, so just to give you a sense, we were really excited about this component, this interactive voice response. So it's a way you can send out automated messages, but at the same time engage people in the content. And so we sent out these messages. They typically went out on a Saturday in DRC and in the evening. So when most people in the household were home. And during our qualitative evaluation, people were saying that they took the quizzes together as a family. And then Dr. Pitcha was telling them whether they had the correct response or not. And we'll talk later about the process evaluation, but it was just a very low-cost way to be able to engage people in WASHA content using these mobile messages.
We had several important findings during our formative and pilot research. First, we found low knowledge of cholera transmission, and this varied widely among diarrhea patient household members. Some had heard of cholera but did not know how it was transmitted, while others could only name 1 or 2 transmission routes. A few common responses for mode of transmission were by flies, dirt, changes in weather, contaminated water and food, and poor hygiene. Many diarrhea patient household members believed that cholera was spread through bad air or bad spirits rather than water or hygiene. We adapted the flipbook models and mHealth messages on how diarrhea is spread to address common beliefs, and that diarrheal diseases are spread from germs found on unclean hands and in untreated drinking water. The flipbook includes a true story of a family where no one in the household washed hands with soap or drank treated water. And 1 child died soon after arriving at the CTC with cholera, and a second child became severely ill. In the pilot, a participant mentioned the value of the story. Knowledge of cholera and severe diarrhea transmission and prevention was much higher among those in the pilots compared to diarrhea patient household members in the exploratory interviews.
And I also just wanted to say here that this testimonial story of this family where they come to the health facility for diarrhea and someone dies was a true story that we had observed during our surveillance, our diarrhea surveillance. So we were able to really incorporate the testimonials from actual diarrhea patients and their family members as part of the intervention content that we were using.
This is an example of a mobile message on cholera transmission sent as a part of our Picture 7 intervention. The image on the slide also shows delivery of flipbook module in a household.
Yeah, so here you see an example of a voice message. And then we always emphasize that the household members should share the mobile messages and that it's everyone's responsibility in the household to keep the family happy. And again, these were automated calls from a physician at a local cholera treatment center.
Another important finding was that many diarrhea patient household members reported running out of soap for hand washing due to financial insecurity, and some faced challenges finding water for hand washing. While some said ash was an alternative to soap, they were hesitant to use this method because they had never tried it. To address concerns, promoters taught households how to make soapy water from water and detergent powder. To encourage children in the household to wash hands with soap, we developed a song sung in the melody of a local nursery rhyme about when and how to wash hands with soap or ash. Lastly, to address the finding that remembering the key times for hand washing was difficult, a cue to action card showing the key times to wash hands with soap was created to place on the wall near the household's hand washing station to serve as a reminder to perform these behaviors. This is an example of how to make soapy water using small leftover pieces of bar soap.
Yeah, and it's went really well in the communities because everyone has small leftover pieces of bar soap, so they were able to utilize them to make soapy water in a much larger volume of soap than they could using the small leftover pieces of bar soap. And so, in an area where it was a high financial insecurity, this provided an easy method to produce soapy water in the household.
In total, we had 518 participants in the 3-month randomized pilot or phase 2. Participants were diarrhea patients and their household members. Standard arm households received the standard message given in the HIP facility on oral rehydration solution and the basic 5-minute wash message given by the government of DRC, and the Picture 7 arm received our intervention program. In the standard message arm, hand washing with soap at key events in household with diarrhea patient was low during 5-hour structured observation, which was consistent with the interview results, where participants say they were no longer at risk of cholera because this was the end of the 7 days high-risk period. The number of households treating their drinking water with chlorine began to decline after the first month. This is understandable as the chlorine we gave them was mostly finished. Although pilot participants were able to find chlorine tablets locally, some said that locally available ones were of inferior quality compared to ones provided during the intervention. To address this, we measured the chlorine concentration in 2 commonly available chlorine tablets in the local market and found that they were of equal quality to Aquatabs. We showed photos of them and conveyed this to participants during free book delivery. To address affordability concerns about the chlorine tablet, we noted that chlorine tablets were 1 out of 8 the cost of boiling water.
Yeah, so that was a really important point that people thought that the locally available product was inferior. And so we wanted to know ourselves, so we were able to test it in the lab and then explain to participants this works equally as well as the products that are foreign that often NGOs were providing in the area, so that there was a locally available source for chlorine tablets. And the price was rather low for the tablets, and we emphasized that also as part of the behavior change communication.
Overall, these findings demonstrate that delivery of the Picture 7 wash pictorial model by a health promoter and provision of soapy water bottle to diarrhea patients and their family and caregivers in health care facilities presents a promising approach to increase hand washing with soap among this high-risk population in Eastern DRC.
Hello, this is Alan Mishingo, Assistant Scientist from the Catholic University of Bukavu in the DRC. I am the evaluation team lead for the Picture 7 program. I'm grateful for the opportunity to present here on the Picture 7 study. I led the analysis I will present today investigating the effects of Picture 7 on hand washing with soap among diarrhea patients and caregivers in health care facilities in the DRC.
And so we know that hand washing with soap among diarrhea patient household members doesn't just occur in the home during this high risk period, but also often these diarrhea patients are and their household members are in the health facility, particularly the family members of the patients are caring for them in the health facility, cleaning up their vomit, cleaning up their diarrhea. So in our behavior change communication module, we really emphasize the importance of hand washing with soap in a health facility setting in addition to the home. So this portion presentation given by Dr. Alan Mishingo focuses on our work to try to increase hand washing with soap in a health facility setting among diarrhea patients and their household members.
The study I will present today is published in the Journal of Tropical Medicine and International Health. I'm sharing my email address here and at the end of my presentation. I hope to meet all of you in person next year. The Picture 7 program includes a healthcare facility visit provided at the bedside of the diarrhea patient to the patient and the accompanying household members. During this visit, a pictorial wash module is delivered by health promoter on cholera and diarrheal disease transmission and hand washing with a cleansing agent. We conducted a randomized pilot of healthcare facility delivery of Picture 7 among 284 participants from 27 healthcare facilities. The standard message received the standard message given in DRC to diarrhea patients on the use of oral hydration solution and a basic wash message during the time of treatment in the health facility. The Picture 7 arm received the Picture 7 wash pictorial module delivered besides by a health promoter to the diarrhea patient and accompanying family and caregivers, and a soapy water bottle for hand washing in the healthcare facility.
So this was a pilot again, but we wanted to make sure it was across many health facilities. So you can see we included 27 healthcare facilities in the pilot.
Within 24 hours of intervention delivery, 3 hours structured observation of hand washing practices at stool, vomit, and food-related events was conducted in the healthcare facilities with diarrhea patients and the accompanying family and caregivers. Key events related to stool and vomiting were observed at different times. After going to the toilet, after defecation, after vomiting, and after washing the child's anus. In relation to food, key events were observed before preparing food, before eating, and before feeding someone. Now, I will explain the study result. It was found that hand washing with soap during key events was higher in the Picture 7 intervention arm compared to the standard message arm, with 40% of patient attendance and diarrhea patients washing hands after the Picture 7 intervention, compared to 14% of patients and 16% of attendants in the standard arm. In conclusion, the Picture 7 program significantly increased hand washing with soap among diarrhea patients and the attendants in a healthcare facility setting in Eastern DRC. Additionally, delivery of Picture 7 to diarrhea patients and the attendants presents a promising approach to increase hand washing with a cleansing agent among this high-risk population in healthcare facilities in Eastern DRC.
And so in terms of operationalizing the findings from this, the work that Dr. Mashinga did on this intervention led to this being incorporated in the WHO guidelines and their operational guide around WASH behaviors in health facilities. Because often, again, there's the focus on the healthcare providers and on the patients, but little focus on the patient attendants, who are often the family members. And so based on this work and similar work that was conducted in Bangladesh, this is included as part of the WHO operational guide around preventative WASH behaviors in health facilities. So now it's me. So I'll be presenting now on the study design of our randomized control trial, the preventative intervention for cholera for 7 days, that you've already heard so much about. And so the design of our randomized control trial was that we had 2 different study arms. We had a total of 2,334 participants that were randomized to either receive a standard message on oral rehydration solution for dehydration and a basic 5-minute wash message, or the same standard message given by the government of DRC and our Picture 7 program. And these patients were coming from Bukavu, which is in South Kivu province of DRC, and we recruited them from healthcare facilities. And you already saw the design of the intervention, so I don't need to go through in detail, but we have an in-person component in the health facility, quarterly home visits, meaning 4 visits over a 12-month period, and then these weekly voice and text messages from a physician at a local cholera treatment center. And so diarrhea patients were recruited from our ongoing diarrhea surveillance system in South Kivu, which includes 115 healthcare facilities. We also have an enteric disease microbiology laboratory in Bukavu, DRC, where we perform analysis of both water and stool for enteric microbes. And here we have an article we recently published validating the use of a rapid test for cholera in comparison to bacterial culture and PCR at our site. And so in terms of our study design, we recruited diarrhea patients at baseline in the health facility, as well as their accompanying household members. We then went to the home and enrolled those present in the diarrhea patient household. We followed all these individuals longitudinally for 12 months, and this included monthly clinical surveillance to obtain information on reported diarrhea, which was defined as 3 or more loose stools over a 24-hour period in the past 2 weeks. We also measured the height and weight of children at baseline at our 12-month follow-up. And we had our intervention fidelity indicators, which included 5-hour structured observation of hand washing with soap practices in the household and unannounced spot checks to collect a sample of stored drinking water to test for both free chlorine concentrations as well as for E. coli. So now I'll go into our health outcomes. And so we found that delivery of the PITCHA-7 program led to a significant reduction in diarrhea prevalence over a 12-month period. And again, this was from our monthly clinical surveillance visits. And this impact was more than a 60% reduction in diarrheal disease that we observed. And this significant health impact was not only for children under 5 years of age, but for all age groups. And so it showed that this intervention significantly reduced diarrhea, not only during the 7-day high-risk period after the patient is admitted to the health facility, but led to sustained reductions in diarrhea over a 12-month period. Next, we were interested in looking at severe forms of diarrhea. And so we looked at diarrhea with rice water stool, which is a hallmark sign of cholera. And so we found a more than 50% reduction in participants having diarrhea with rice water stool during our 12-month surveillance period in our PITCHA-7 arm compared to our standard arm. Next, we looked at healthcare facility visits for diarrhea, a very important outcome when thinking about the cost effectiveness of this type of intervention. And we found that there was, again, a more than 50% reduction in health facility visits for diarrhea in our PITCHA-7 arm in comparison to our standard arm. And so these findings showed that the PITCHA-7 program was not only effective in reducing diarrhea prevalence, let's say mild to moderate diarrhea, but was also effective in reducing severe forms of diarrhea. Next, we looked at our outcome in stunting, which is kind of an elusive outcome, right, when we think about WASH. And so we measured stunting at baseline, as well as our 12-month follow-up in children that were under 5 years of age. And you can see, as expected at baseline, the stunting rates were similar between the 2 different study arms, with red being the standard arm and then blue being the intervention arm. But then when we go out to our 12-month follow-up, we observed that stunting was significantly lower in the PITCHA-7 arm compared to the standard arm. And this reduction is a 19% reduction in stunting. So we reduced stunting by 19% in the PITCHA-7 arm compared to the standard arm. And another thing that's interesting here is that when you think about what WASH can actually achieve, so we didn't reduce stunting among those that were already stunted. What we did was we helped to prevent subsequent stunting among this high-risk population. So to summarize our health outcomes, we observed that delivery of the PITCHA-7 program resulted in a significant reduction in diarrhea prevalence over a 12-month period. And again, this was not only for children under age 5, but for all age groups. We observed a significant reduction in health facility visits for diarrhea, as well as diarrhea with rice water stool, which is a hallmark sign for cholera. We observed a significant reduction in stunting for children under 5 years of age. And just to take you back to our work in Bangladesh, we observed a comparable reduction in stunting with a similar intervention approach that was then adapted to this context. And so now Kelly Andreas will go into our WASH behavioral outcomes.
Great, thank you so much, Christine Marie. As she said, my name is Kelly Andreas. I'm with Johns Hopkins. I'm very excited to be presenting these to you today. So to go with the health outcomes, we were also looking at the behavioral outcomes of our intervention. So just to remind you, there were 3 key behaviors we were really targeting here. So this was hand washing with soap at food and stool related events, This was water treatment and then also safe water storage. So for our first outcome, we were really excited to see that the PICHA-7 program resulted in significantly higher hand washing with soap during food and stool-related events. This was not only at the 7-day high-risk period, but also sustained through our 12-month follow-up. And so you can see compared to the PICHA-7, or the PICHA-7 arm compared to the standard arm is much higher. Next, we were looking at stored water chlorination. So we found that the PICHA-7 program also significantly increased stored water with free chlorine greater than that 0.2 milligram per liter. And again, this was at the 7-day high-risk period and sustained throughout the study through the 12-month follow-up. And then finally, we were also looking at the E. coli concentrations. So we saw that a significantly higher proportion of PICHA-7 households had E. coli less than 1 colony-forming unit per 100 milliliters compared to the standard message arm. And this was sustained across the 12-month follow-up period as well. And so then finally, that was short, but really just to emphasize that we were able to increase our targeted key wash behaviors. So this was a significant increase in hand washing with soap, a significant improvement in stored water quality measured through the increase in chlorination and a decrease in E. coli concentration. All right.
Hello.
So that's my program. And next, we'll have President Senvora, the data manager and kind of all-around person for our study site in DRC, talking about the process evaluation. And Presence is online. We had them record because we were worried about internet issues, but he is online to help answer questions after the session.
Hello, I'm President Senvora from Université Catholique de Bukavu in Democratic Republic of Congo. Today, I'll be discussing the process evaluation we conducted on the preventative intervention for cholera for 7 days or PICHA-7 program. I'm the DRC-based data manager and project coordinator of PICHA-7 research program. I look forward to meeting all of you in person next year. Here is an overview again of the PICHA-7 mobile health program. Weekly voice and text messages were sent for 12 months to the program households. The mobile health component was developed during intervention planning workshop after the development of initial picture modules. It aligns closely with the picture modules to target facilitator and barriers to promoted wash behavior identified during exploratory research. We used 3 types of mobile messages. First, we used the interactive voice response or RVR quizzes. Second,
Yeah, so here Presence is presenting on the different types of mobile messages that were delivered as part of the program.
I lost the mouse away.
We'll present it, and I can present it. I hope that he comes back soon. And so here we show the target wash behaviors. I should take the mic for people online.
I think it's on.
Okay. So here we have the different target wash behaviors that were included as part of the mobile health program. So
secondly, we used the voice calls, and the last we used the SMS messages. The Engage Spark platform was used to deliver messages for the PICHA-7 mobile health program.
Sorry about that, I think I paused it.
2 characters were created. Dr. Picha, a really doctor at the cholera treatment center who treats cholera and severe diarrhea patient that was renamed for this intervention, and Mwanza, a mother of a young child that fell ill with cholera and needed to go at the hospital for the treatment. Now I would like to describe the study design for the process evaluation of the mobile health component of the Picture 7 mobile health program. Diarrhea patients and their household were followed for 12 months. Monthly questionnaires were administered to the study participants to determine whether they received mobile health messages during the study. The Engage Park mobile health platform, which was used to send the Picture 7 mobile health messages, also provided information on whether mobile messages were received, how long they were listened to, and the response given for the RVR questions. First, we look at the message fidelity, which is the percentage of unique text, voice, and RVR messages sent to the household that were received. A high percentage of all messages were received for SMS text messages or answered for voice and RVR messages by household. 84% of unique text messages were delivered, 86% of unique voice messages were fully listened to, and 78% of unique RVR were fully listened to.
I just want to explain something on this slide quickly. So as Presence was saying, we use the mobile health, a mobile platform called Engage Spark to send out our mobile messages. And this was extremely valuable because we were able to get information on whether people actually received the text messages that we sent, the duration, we can see how long they listened to it, if they fully listened to it. And so the platform is low cost, it's not expensive. It allows you to set up the timing of the messages. So to send people, let's say you call them, they don't answer, you can call them back after 5 minutes, after an hour and a half, after 3 hours. And so it's just a really valuable approach to be able to send out the mobile messages. And as you can see here, many of you are probably familiar with the DRC context. But this mobile health program was successful, we think, because we were able to resend calls. If there was a network issue, if households didn't receive them, then we can send them out multiple times to make sure they were receiving the content. And we could also see, which Presence will present in subsequent slides, when we ask people those questions, we can see what they answered. And so it's just a really valuable platform to be able to also do process evaluation at the same time and see how the mobile health program was going.
Using the Engage Spark platform, we know how many households received messages, and we can also look at the response to the RVR quiz messages. During the study period, households received weekly 1 quiz and 1 voice call. Overall, all households replied to at least 1 RVR message. On average, 60% of messages received were replied to correctly. Sometimes, program household did not press 1 or 2 in response to an RVR message and instead press an invalid response such as 3. This was found to be 22% during the study period. Picture 7 household reported receiving a program mobile health message in the past 2 weeks at 72% of the surveillance visits. This was 58% for caregiver of young children and 48% for participants overall. The percent messages received was fairly consistent across the study periods.
I just wanted to say something here also. So we had the platform, but we also asked households whether they received the content, because we know not everyone in the household has a mobile phone. So this is showing during the household visits the percentage of people who reported receiving the message, even if they didn't have a mobile phone themselves.
In conclusion, we found the high fidelity, dose, and the reach for voice and RVR calls and text messages delivered for the Picture 7 mobile health program. Our results show the feasibility of delivering the Picture 7 mobile health program in our study settings in Eastern DRC and provide important assigns for developing mobile health programming in the low and middle income countries globally. Finally, the Picture 7 mobile health is a promising approach to increase WASH behaviors and reduce diarrhea and starting in DRC.
And so now we'll go into the final part, and then we're going to open the floor for questions. I'm really looking forward to the discussion that we'll have about transformative wash. And so I'll summarize our overall findings from our randomized control trial as well as our earlier formative research and pilot activities. We observed in our randomized pilot that delivery of picture 7 resulted in a significant increase in hand washing with soap in a health facility setting among diarrhea patients and their attendants. And as I mentioned, this was able to be incorporated into the WHO operational guidelines around wash preventative behaviors in health facilities, which came out, I think, 2 months ago. We also observed, when you just saw the process evaluation for the mobile health program in picture 7, that we saw a very high fidelity dose and reach of the program to beneficiary households, even in our setting, which is in Eastern DRC. In terms of our wash behaviors, Kelly Andreas presented on that at the household level, and we saw significant increases in hand washing with soap, water treatment practices in terms of the presence of free chlorine, and also in terms of reductions in E. coli in stored drinking water. And this was, again, not only for the 7-day high-risk period, but sustained out to 12 months. And then in terms of our health impact, we saw significant reductions in diarrhea prevalence over a 12-month period, collected in a rigorous way through monthly clinical surveillance visits. And we also saw significant reductions in severe forms of diarrhea, including health facility visits for diarrhea. And then finally, we observed that delivery of this program resulted in a significant reduction in stunting for children under 5 years of age. And when we think about our intervention, this finding really shows that this program that integrated both mobile health messaging with in-person visits in our study setting in Eastern DRC led to significant reductions in diarrhea prevalence as well as stunting among diarrhea patient households. And compared to many other wash interventions, it was much less intensive in terms of the in-person component. So we had this in-person visit in the health facility, we had 4 in-person visits during a 12-month period, and then we had these weekly mobile health messages over a 12-month period. And many of the community-based wash programs that we see are going to households every 2 weeks or every month to deliver the program. So this was much less intensive in terms of in-person visits. And it shows that the mobile health component likely was highly beneficial in terms of serving as reminders for people to adhere to the promoted wash behaviors. And so next, I kind of wanted to take a step back and talk about the evidence that we gained. So in the beginning of the presentation, I talked about our work for the Shobi 7 program in Bangladesh, where we delivered a similar mobile health program that integrated both in-person visits with weekly voice messages from a doctor at a diarrhea hospital. And we showed there that it reduced diarrhea and stunting. And then we saw similar findings in DRC, which is a very distinct context for the reasons that I mentioned: water scarcity, food insecurity, financial insecurity. And so this provides compelling evidence that this type of intervention works. And so given this evidence, we would like to encourage public health practitioners and WASH practitioners to integrate this form of intervention where they have mobile health messaging and in-person visits in their existing WASH programming and consider it in their future WASH programming. Mobile health messages are very simple to send out. It's a low cost, as I mentioned, $2 to send out weekly messages. And so we're very interested to have a discussion after we take questions on how you could potentially integrate WASH mobile health messaging into your current work. And so with that, I would like to acknowledge my collaborators at Catholic University Bukavu, and some of them are here virtually to address your questions, as well as my colleagues at the DRC Ministry of Health and Johns Hopkins, and also our funder for this trial, which was welcome. And here I show a photo of our study team based in Bukavu on beautiful Lake Kivu. Come visit us. And then we're happy to answer any questions. And we have the 3 publications that are currently out based on this work. We have 4 more publications that are in various stages of review related to this trial, and we hope to be able to share those with you next year. And so we're gonna address questions, and then I guess we'll address questions first, and then we'll go into our transformative WASH part. So we hope you have lots of questions for us.
Should we see if Presence and Jean-Claude can?
Yeah. So Presence, if you're there, you can say something to us. Yeah, I think they were facing some technical difficulties, but we're happy to address any questions that you have.
Hi, I'm Andres, and I work with data for development. So it was really nice to hear the fidelity rates reported, because that's really high for SMS data collection. 80% and above is, quite amazing. So I wanted to know, how do you, can you attribute anything that you did in the program? Maybe did you give incentives, or was there a really strong programming through, or participant filtering that you did in order to ensure this fidelity, or was it a surprise to you guys too?
So we were really excited to see the findings, and we attributed them to the 18 months of community-centered formative research we conducted to adapt the intervention to this context. And so things that emerged that were really important was giving an intensive tutorial in a health facility setting to the diarrhea patients and their household members on how to receive our messages. The EngageSpark platform allows you to enter a short code into the person's phone, and then they automatically are enrolled in the mobile health program. And then they can receive a test call while they're still in the health facility. So you can show them how to press 1 or 2 in response to a question. They can listen to the voice of Dr. Pitcha. They can check to make sure they're receiving the text messages that we're sending. So I think that initial step to ensure that the mobile health component was going to work well helped to ensure the high fidelity dose and reach we saw later. Also, we emphasized the importance of mobile message sharing. We know that we're in a context where it may be that not everyone has a phone, or not everyone does have a phone. And so it may be that one household member in our context, typically the male head of household, may have the mobile phone. And so making sure that he's sharing that. So really encouraging that in the initial stages of the intervention. Something else that was important is the timing of message delivery. So making sure you're sending it late enough in the evening so that the person that has the phone is home. Sending it on the weekends when we ask the quiz question, when people are together as a family, it allows for family engagement. And so I think those type of factors contributed to the success. For the voice messages, also resending the messages if they didn't answer the first time was another way to help people. Because sometimes people reported that they were doing something else when the call came, so they couldn't answer it. In the health facility, we also saved Dr. Pitch's number to their phone, so they're able to tell if it's her versus another person that's calling them. And so really people reported that they appreciated that a doctor from the health facility was calling them to follow up with them, and it showed that they cared about them and their health.
Dr. Picha was a real doctor.
So she was a real doctor. We renamed her for our intervention. Her actual name is Dr. Raisa. I don't know if she's online right now, but we named her Dr. Pitcha and named with our intervention. But she was a doctor at the Cholera Treatment Center. Are there other questions? Yep.
I was wondering whose idea it was to take the small pieces of soap for making soapy water, if that came from Catholic University Bukavu or the community, or from Johns Hopkins.
So some people actually practice that in the community. And the funny thing is, when I was growing up, I had a great aunt that was alive during the Depression. And she always did this in our house. She made soapy water. But it also came from our team in DRC. They were very interested in ways that we could make a low-cost version of soapy water, because in the Congo context, the detergent powder is not as available as it is in, let's say, Bangladesh. Are there other questions? Yeah.
I'm wondering what the baseline diarrhea incidence is in this area.
So for children under 5, it was really high. It was over, was it 25%? It was around 25%, and then overall it was high too. It was around like 14% for all age groups. So it was a context where diarrheal disease rates were very high. And as you saw when I showed the slide with stunting, stunting was 50% of the children had stunting at baseline, which is very high. And you rarely see that in other types of WASH studies. And I think it's our context. We're in a context that has conflict, food insecurity, and so the stunting rates and the diarrhea rates are extremely high. And we also attribute the success of our study to that context because it allowed for more room for improvement for WASH interventions.
And I have like a second part of my question to you, which is, I think you mentioned having maybe 500 children under 5. I'm wondering how many of those were under 2 or under 1, and if the effects were different or perhaps greater for like this youngest age group.
Yeah, so we did look at the analysis separately for children under 2, and we didn't see a stronger impact because we know that in Amy Pickering's study in Mali, she saw a stronger impact for under 2, and in Bangladesh, we saw only a significant impact for under 2. But in our context, it was similar for children under 2. There wasn't a greater impact.
That's interesting, actually. That's quite related to one of the things I was going to ask you about. So I'm really interested in like where people contract enteric diseases. So the intervention you did was within the home context, home hand washing and home water treatment. So I'm wondering whether you collected any data on how much water people drank outside of the home that wouldn't have been their chlorinated water source, and also whether the improved understanding of the importance of hand washing increased people's hand washing in other contexts, if they were in the market or in the school, whether they had been then sensitized to that importance.
Yeah, so those are great questions. And so we did have a question in the questionnaire about other sources of water people got. Did they get it from the school? Did they get it from, like you said, the marketplace, somewhere outside their home? So we have information on that. We haven't analyzed that yet as a risk factor, but I think that's going to be something really interesting to look at. In terms of hand washing practices outside of the home, I would love to explore that to see if the intervention that's this mobile health component would have impacts on behaviors outside of the home. We saw impacts in the health facility, in the home, but we don't know outside of that space. So that's a great question.
There's not high availability of hand washing materials outside of the home, I think, in the context.
Yeah,
right? So
during the pandemic they were there, but not now.
yeah, so it would be challenging.
Yeah, but interesting whether people would like wish to, if they had the opportunity to wash
And
them.
Kelly, you should come up because you're answering questions too.
Sitting just felt so nice.
So you have other questions for us?
This is great work and really meaningful, so thank you for sharing. My question is, because I'm curious on your side, if you could explain more the possibility of scaling this up to the different communities, or if you're looking at different countries, since from what I'm seeing, I guess it's the quarterly home visits, so like 4 times a year, and then the weekly messages. So it doesn't seem as much like capacity, but I don't know, is it more that I'm not realizing, or is it more scalable than?
Yeah, so we think it's a lot more scalable than other types of studies. And in our context in Bukavu, there's a community health worker infrastructure that's already there. And so the home visits that were conducted were not very long. And so this is something that could be integrated into the existing community health worker activities. And so we share these findings with the provincial Ministry of Health as well as at the national level. And there definitely is the interest in scaling, but it needs to be tested in more diverse contexts. And so some of our upcoming work is going to be in internally displaced persons camps to see if this form of intervention will work. Congo has some of the highest rates of IDPs in sub-Saharan Africa, but there being 5.6 million internally displaced people. So we're planning to test it there. And so I think testing this approach in different contexts is really the next step, but there definitely is the interest in scaling this type of approach.
Great, no, that's good to hear, thank you.
Are there other questions? Yep. Oh, either one.
Thank you. I was wondering if you had any intention of maybe going back. I mean, you did it for 12 months. I was wondering if you had any thoughts of maybe going back and seeing where these habits kept up. Did disease overall go down, or, I mean, a future plan obviously, but.
Yeah, so we're interested, we're actually working on now going back and measuring the height and the weight of children that are under 5. We're really interested to see how not only this intervention impacted growth at the 12-month follow-up, but how it affected their growth trajectories over time. And I think that's a limitation of a lot of studies, right? They stop at 12 months and then they're not following up again. So we're really interested to go back and look at that. So that's a great question.
Can you, like, from your experience with mobile health monitoring, can you touch a little bit upon the digital and tech barriers maybe that you encountered, or?
Do you want to talk about that?
Yeah, sure. I think a big one we definitely had, as we saw with the invalid response rate, was having people understand the correct way to respond to a message. We actually had very limited issues with message failure. So I think it was like under 1% of messages actually failed when they were going out, which we were really surprised with. But some of it was like people not having time to answer the messages was a big one, and then bad service was a problem, so that they couldn't hear the message well. Like they could receive it, answer it, but then the sound quality wasn't.
The damaged
Um,
phones.
Yeah, damaged phones, lost phones. Also in this context, people change their phone numbers sometimes. If you're getting a new SIM card, your number would change. And so that's another problem we would have. And so when during our other visits, we would always ask if there were new phones in the household or different phones that we would then enroll into the program. Yeah, those were our big ones, and we would send the messages multiple times to make sure that they were receiving at least one version of each message, which was helpful as well.
And we got qualitative feedback. We also wanted to make sure we didn't send out too many messages to people, right? Because that's also a challenge. You could overload people. So we made sure during our piloting to do really intense qualitative research to really understand how much was too much, how much was enough. And so we found that resending 3 times, that's the limit. Don't send it more than 3 times. Were there other questions? Yep.
I actually had a couple of questions about the presentation. I really thoroughly enjoyed your presentation. So my first question is, seeing that the program delivered in Bangladesh and the program delivered in DRC have similar outcomes, what led to the integration of the quarterly home visits that were integrated in this program? And then the second question is, what do you think is the major factor that helps sustain the reduction in diarrhea occurrence rate among children past the duration of the 7-day delivery of the program?
So those are great questions. So for the first part of the question, we incorporated the quarterly home visits because there was a community health worker infrastructure that was already present in the area, and we wanted to make sure we were integrating our activities into the activities that were occurring there. There was wash communication occurring from community health workers, but it wasn't really standardized. And so this provided a way to have a standardized approach to incorporate to target diarrhea patient households in our context. And so that's why we decided to do quarterly home visits in this setting. In Bangladesh, it just wasn't feasible. So there wasn't that same community health worker presence there. And so that additional in-person component was not feasible and wasn't needed. And then what was your second question again?
It was just, what do you think is the major factor that helps sustain the reduction in diarrhea occurrence rate among children past the duration of the delivery of the program?
So we think that we don't know conclusively because we had different components, right? We had our in-person visit in the health facility, quarterly home visits, and the weekly mobile messages along with the hygiene kit. But qualitatively, when we interviewed the participants, they really liked the mobile messages. They liked the reinforcement over time. They liked the interactive component in terms of the interactive voice response. The in-person visits were important for addressing technical challenges, like their hand washing station wasn't functional. How do they fix it? We didn't provide them any replacement parts, but we could explain them how to fix it. Some households, it was damaged and they had to make another one. And so the community health workers were able to explain that. And so through that, we think it's just a multitude of components that contributed to the success past the 7-day period. To really hone in on what it was, we would need to conduct a randomized control trial that had different components and then look to see which one was having a greater impact. Are there other questions? You had a question, Sarah, right?
I did, yeah, I don't remember if you covered this, but what percentage of participants already had a mobile phone before the study?
So I think it was around 80%. We didn't provide phones, so we should make that clear because I think sometimes people think we provide phones. And so the feature phone rate was around, it was split. So some people had feature phones and some people had smartphones. And when I say feature phones, I mean like the block type phone. And so we should mention for people who did have smartphones, we were able to share their video content from our study, which was really nice. But yeah, we didn't provide mobile phones as part of the study.
Yeah, on average, there's about 1 mobile phone in households at all times.
That's nice.
Yeah, we were really excited to see that in DRC because it means if in DRC we're seeing this, theoretically it should be possible other places as well. So.
And it was just really interesting for us, the process of adapting this intervention from Bangladesh, which is just such a different context. And we should also say that our colleagues in Bangladesh also contributed to this, where they provided support to the teams in DRC as they were going through the formative research. So it was definitely a partnership.
Yeah. Well, and now our DRC team supports the Bangladesh team as well, so
they
it goes
have-
both ways.
And they have cross publications, so they've been publishing papers together, so it's been a really great partnership. So before we go into the group discussion, are there any other questions for us? Yeah.
One question. I wonder if you can say just a little bit about like water availability and what types of water sources people were using and yeah, just like how that might affect speech protection.
So there is a municipal water supply for some areas, and they are providing some levels of chlorination. So if you remember our free chlorine slides, when you looked in our standard arm, there was like around 20–30% chlorine over 0.2 in the standard arm. A lot of people were relying on springs and other types of water sources that were installed by NGOs. So it was a combination. In terms of like the basic definitions, do you remember what percentage were basic? I would have to go back
The
and look.
majority were basic.
Yeah, the vast majority were basic.
But also part of our criteria was we were not including households that had water access in the home. So none of our households had like piped water access in their home.
Yeah, tap water.
Yeah, or tap water connection, yeah.
Are there other questions? So we're really excited to hear from you. And so in the last part of the presentation, we just wanted to hear from you as WASH practitioners or whatever the space is that you're working in. If you've had experience using mobile health messaging for WASH, and how you envision that mobile health messaging could be incorporated as part of WASH programming. So we're really interested to hear from you and your experiences. Yep.
Yeah,
You say further.
I wasn't directly involved with this program, but my organization, AGBO, we have presence in East Africa and in Kenya during the COVID.
I'm sorry, Vivi, because I'm not sure if it's connected for the mic for people online. People online, I don't know if they can hear you.
Hi, my name is Andres, and yeah, I was just gonna share our experience with AGBO. In Kenya, we worked with USSD technology, so this was during the COVID crisis, and basically we were collecting risk level information for families that might experience food shortages and also that had WASH concerns at the household level. And we partnered up as well with a radio station that was monitoring the information that was coming into the database. I was sharing like live updates, and they were also like spreading awareness of the campaign through the radio. So that was a good partnership that we established. And I don't have specific results that I can share right now, like off the top of my head, but I can probably share like a case study or something like that.
That's great, I would love to see that. And what about the mobile health messaging? Did they send out any voice or text messages?
It was just SMS, yeah, through USSD.
Okay.
Was it a lot of people with smartphones, or was it not that mostly the flip
Mainly,
phone?
how did you call them? Feature phones.
Feature phones, yeah.
Interesting.
Yeah, and USSD, I don't know if you guys used USSD.
No.
So I don't know if I can explain that like correctly, but it's basically, it's called unstructured standard message delivery or something like that. You program it and it sends the messages on its own. And it has like, it's like a question tree, so with multiple choice. Sort of like when you go on WhatsApp and you talk to an operator or like an airline or something, it has like the standard messaging with the options. And then you answer and it gives you like, it sends you to question 4 or you skip to question 6 depending on what you want.
That's great.
Yeah.
So was it like a hotline then, and they would call in and they can answer a series of
Sort
questions?
of, yeah.
Okay.
Exactly.
Oh, that's really valuable. Thank you for sharing.
So for something like that, how do you kind of make it clear to people that they don't have to pay for their responses?
Yeah, I mean,
If you know what they did for that.
it was mainly through the campaign.
Okay.
But also like there wasn't enough like space to do like this sensibilization that you guys did. So the response rate was much lower. I think it was maybe 10–15%.
Yeah, because that's definitely a concern we had sometimes. It was easy to explain, but that people were like, oh, I don't want to pay. I'm worried that it costs money to pay for responses.
Yeah, so in our health communication, we actually, when they were in a health facility, we explained that they're not going to have their credit cut. And then they're entered into the platform using a short code, and then they receive a call and respond to an IVR message. We want them to check their credit. So they can see that we didn't take anything from their credit. And also in our mobile messages, we state that you're not going to be charged for pressing 1 or 2, so they know. And in Bangladesh, that was a challenge also, that people thought their credit was going to be cut. Because apparently there's scams that do that. If you respond, then you're losing credit from your phone. Yeah, but thank you for sharing your experience.
Sure.
Did other people want to share also? Even if you're not practicing current work in the space, how do you envision that mobile health messaging could be incorporated as part of WASH programming? Or what are some of the challenges that you see with that? That's also valuable to hear from you in terms of the challenges.
I'm a PhD student at the University of Leeds, and I feel like more and more I'm hearing people talking about like citizen science and mobile phones as like a really valuable tool. So I guess the only thing I was going to kind of respond is that it seems to be increasing, and because there is such a high coverage of mobile phones, it's a valuable tool. I guess the challenges are like if people who are not experts at collecting data, then obviously you have to make sure that they're collecting something that's relevant and valuable. But I think overall it's a really cool opportunity.
Thank you. Yeah, so some of the challenges that we encountered when we were first doing it is we wanted to give people too much information. And so some of our calls were 3 minutes, and no one wants to listen to a 3-minute call from Dr. Pitcher. And so we learned through experience to try to keep it shorter, keep it around 60 seconds, 75 seconds. And the same thing with the text messages, that we should really try to stay within 300 characters. If you go over 300 characters, you get charged for another SMS message. And so it also ends up being more expensive. And so we learned a lot through that. Something also that's interesting is that when we started our work in Bangladesh, we had a male Dr. Chobi. But the male Dr. Chobi did not work well. And so in our contacts during our qualitative work, it came out that males head of households said that they didn't want a male calling their wife's phone. And so we had to change that. But it was good that we had conducted our piloting, so we were able to identify that early on as being a challenge. And also we had different photos of what the doctor looked like. And we had focus group discussions where we got feedback. Because first we had, you can see Dr. Chobi is on the right, and then Dr. Pitcher, they're both there. Dr. Chobi is on the left, and Dr. Pitcher is on the right. We had a very young version of the doctors, and they weren't seen as trustworthy. And so we had to get more doctors that were a little bit older to be the physicians. And so it was a lot of iterations of intervention development as we went into the mobile health space. And I should mention, these 2 randomized control trials that we conducted are the first randomized control trials of WASH mHealth program. So there had never been a randomized control trial of a WASH mHealth program before these studies that we conducted. So really in the space, there's a need for evidence in different contexts globally on whether this approach is effective, because every context is so different. It may work well in DRC and Bangladesh, but there may be major challenges in another context. And so we really encourage people to consider building evidence in other contexts on this approach.
Especially in terms of behavior change. I know it's used a lot for, even in Africa, for like medication reminder, behavior change type stuff. But yeah, we haven't seen it much for WASH.
Yeah, excellent work. Excellent job, super interesting work. I've always wondered about using this for household water treatment technologies. And so I'm Sarah Beck with the University of British Columbia. And we've wondered about things like my biosand filter is clogged and what should I do? Or things with pit emptying or UV light, we need a new lamp, we need a new replacement, things like that. But I've always been concerned that that the communities wouldn't be able to either afford a phone or to be able to pay to keep it charged. So it's super encouraging to hear that they can even in South Kivu. And then I was also worried about it being annoying, like you think of when you get telemarketers or like
no more than 3 times.
Politicians calling. Yeah, so that's good to know. So great job.
Thank you.
Did you want to mention the costing for the messages?
Yeah, so the cost over a year to send the weekly messages is $2 US. It depends on the local telco and the countries that you're working in. And so something we're currently using the EngageSpark platform for the voice messages, but we're interested in also working with countries to strengthen capacity around having this be more scalable. And so in Bangladesh, we're working with local telcos for them to customize within their own platform, their own delivery system. And so that'll make the cost even lower for message delivery. And we've been trying to do that at DRC, but I've had limited interest, but we're gonna keep trying.
I just want to make sure that I don't give you false information. So the USSD is actually it's referred to as short codes. So it's those codes that you type in like asterisk 99.
Oh, okay.
And it sends you to, it opens a conversation, like a two-way conversation with a provider that you can gather multiple questions. It's not just one like SMS, you send the text, that's one, then you get a response, that's another one. So also for collecting data is also more, I guess, it gives you a bigger opportunity to capture like, for one string of data, which would be one respondent, you can gather multiple questions in one string of data.
That sounds valuable, really valuable.
So I just wanted to be clear with that. I double checked just in case.
Thank you. So are there other comments? What do people think some other challenges could be with integrating mobile health messaging into watch programming? Your phone accessibility is definitely a challenge in some contexts. But for us, we were actually surprised when we started working in DRC that the mobile health component works so well. But I think as we're going into, as over time, technologies are improving, network coverage is improving, and so mobile health is becoming a more and more promising technology to be able to implement.
Hi, sorry, I came in late. My name is Lisa, I'm from Lazava Water Filters. And sorry I missed it if you addressed it already, but how do you deal with local languages? Because we operate, for instance, in Kenya, and we're always struggling, like, should we do our broadcasting messages in English, or should we do Swahili, or even maybe Kalenji, or any other language? And apologies if you addressed it already.
So that's a great question, and we've been fortunate that the context that we work in, the language has been more homogeneous.
So you selected those guys.
So in Bangladesh, it's mostly it's Bangla. So the mobile health component was in Bangla. We had issues there with the characters. So whether to send out characters or whether to send out phonetic Bangla as part of our messages. And so in the end, we decided to do the characters for that. And DRC is Bukavu dialect of Swahili that's spoken in our area, and so it was in the Bukavu dialect of Swahili. But we're transitioning now to also build evidence in IDP camps. And so there you have different languages. And so there we have to use our IVR feature, we think, where people can select a language, press one based on this language or that language. And also in the health facility, when we enter the short code, we can ask the household what language to enter then, and we can put it in at that point. But that's definitely important to make sure you have it in the language people can understand. So are there other comments? Yeah.
I guess a comment. You mentioning about which characters to use brings the question of the literacy rates as well, and whether reading the messages at all was an issue.
So within a household, 98% of households had at least one person that could read and write. So that was really high. Not all the people. Usually it was a child. Usually it was like the adolescent child in the house that could read. But that was one of the reasons why we always accompany voice messages, and then we have a text message. The voice message has the advantage people like to hear the voice of Dr. Chobi or Dr. Pisha, and they're able to hear them talk, interact with the IVR responses, but then they can't save the voice messages. And so the text messages have the advantage that they can keep them in their phone. And we didn't show in this presentation, we also looked at message sharing. And so people were sharing these messages with their neighbors, their friends, their coworkers. And so having the text message was valuable for that reason, that they could save it and share it with others. Are there other questions? Or comments? What about from the UNC group? What are some challenges that you think we'll encounter?
Bring you on the spot.
That's the first time I heard about
use a mobile phone to get the feedback from the community to get the result to do this research. So I think no more comments.
Yeah.
So
So
good thing for me.
the most common issues were the ones that Kelly highlighted. People's phones are damaged, they're busy, they're not answering the phone. Sometimes people's screens are shattered and so they can't respond. And so those were the challenges, but in the end, they ended up not being major challenges. And it's a really good way to get in touch with people when they're often not at their home. So you go to do home visits, they may not be available, but the text message, people's phones are usually with them most of the time, right? So they're able to get the messages that way. But we should also, again, say that it wasn't just the mobile health component. We still had the in-person visits that were quarterly in DRC and in the health facility at baseline. We had the video testimonials that we gave from community members that were diarrhea patients themselves and perhaps had someone die in their family or had experienced a recent illness. So it was a package that we were delivering, and mobile health was part of the toolkit in that package.
Yeah, I mean, one last comment I had that we already said a little bit, but I just wanted to emphasize is coming into this work a little later on, I wasn't involved in the design of the project or when data collection was starting. I was just really surprised how many people had mobile phones in our context, and when I was looking it up, it was like, I think it was estimated that at least 70% of people in DRC had mobile phones. And I think sometimes coming in, it was easy to think maybe they wouldn't have them, but we are living in a very digitized world no matter where you are. And a lot of people have access to that technology, I think, no matter where you are, so.
And I think going back to what you were saying, Sarah, about the filters, you could definitely use that as a component to troubleshoot the filters and see how things are going. And an example is that in Bangladesh, we have another randomized controlled trial where the hygiene kit is only a soapy water bottle and chlorine tablets. And households have to make their own hand washing stations. And so in our piloting at first, it wasn't going well. Only 20% of people are making a hand washing station. But then when we really adapted our mobile health content to the challenges that they were facing, it increased to 80%. And so now we're conducting a randomized control trial of 1,600 participants of that approach. And things that we had to do was explain the importance of building the hand washing station during the 7-day high risk period. Because some people were just kind of putting it off and saying, oh, well, we'll build it later. Other things where people were concerned, they had iron filters. And so they were concerned about the water that was in the container. Was the water okay for them to use for hand washing? And so through our mobile health messages, we were able to address the challenges that they were facing. Were there other comments or questions or insights? Could you see yourself incorporating mobile health messaging into the activities that you're doing?
I think we worked with UNICEF and we presented this on Tuesday, developing a sanitation portal. And UNICEF is really interested in triangulating information, not only from wash outcomes, but also health outcomes, making sure that we understand the relationship, how do wash interventions actually affect health outcomes, which is something really difficult to do. And one of the limitations that UNICEF pointed out to us is that most of the information related to health outcomes is generated at the point of care, so at the hospitals usually, and a lot of I'm not a doctor or from the health sciences, but the process of the disease happens a lot at home, especially for diarrhea and cases like this that are treated at home. They don't usually get to the hospital until it's too late, or the statistic already changes. So I see there's a big opportunity to improve our data generation and quality, to monitor and track health outcomes via mobile health monitoring at homes. So I think it's a really great innovation that could be really scaled up.
And I think that also came out a lot during the COVID pandemic, right? Because a lot of countries were sending out automated texts or automated voice around hygiene behaviors during the COVID pandemic. And so because of that, a lot of countries have that system in place already. And so there's really the opportunity to scale the delivery of the WASH messages. So with that, we'll do a wrap up to give you back your time. But we just wanted to give an overview. So again, we conducted our randomized controlled trial in Bangladesh and in DRC, where we had this integrated approach where we had in-person visits and mobile health messaging. We saw a significant reduction in both diarrheal disease over a 12-month period and stunting in these two very diverse contexts. We think that given this evidence that people should really try to consider incorporating mobile health messaging into their WASH programming and their upcoming programs as a low-cost approach to facilitate WASH behavior change. And so we're available, Kelly and I, and also our teams in DRC and Bangladesh to support you if you're interested in learning more about how you can integrate mobile health messaging as part of your programs. And so we really encourage you all to do so, and they're also available after the session. And I don't think we have our email address on the slides, but I'm happy to share my card with you, and you can follow up with us if you want to think of other ways you can incorporate mobile health messaging into your programming. Thank you.
Especially our local teams have a lot of experience troubleshooting on the ground, so they're great people to talk to.
Yeah, but thank you for attending our session on Thursday. We appreciate it.
Thank you.
Christine, would it be possible to see the summary slide?
Yeah, let me go back to it.
President sent us photos of the presentation.
Oh, that's great.
They could attend it.
Yeah.
Could they see though?
Yeah, if you see
That was really good. Nice of you. Here's my business card.
Sorry for putting you on the spot like that.
Yes.
Yeah, you're the talented generation.
I don't know.
Oh, okay.
Yeah, so I'm a research associate on